Hello, my name is Yuanxi, a postdoc fellow at Johns Hopkins. Now, I'm presenting our study titled Citation of Prior Research in Reports of Randomized Clinical Trials, a Systematic Review. Sir Newton said, "If I have seen further, it is by standing on the shoulders of giants." In the era of evidence-based medicine, if we have seen further, it is by appreciating prior research. Before designing a new study, the evidence-based research method requires a systematic review of earlier similar studies to ensure that the new study can be justified. But there has been evidence suggesting that researchers may ignore prior studies when designing new studies. The use of prior evidence can be reflected in the citation of prior studies. So, the purpose of the current systematic review was to assess the citation of prior studies in reports of RCTs. We had three aims. Aim 1 was how many RCTs have cited existing systematic reviews for justification. Aim 2 was when systematic reviews are not available, how many prior RCTs have been cited by subsequent RCTs. Aim 3 was when systematic reviews are not available, how many patients recruited in prior RCTs have been cited by subsequent RCTs. We searched PubMed for eligible studies. 2 of us independently screened the title, abstract, and full text to confirm the eligibility of included studies. Studies were eligible if they assessed the citation of prior research in a cohort of RCTs and reported empirical and quantitative evidence. We did not find existing tools to assess the reporting quality and the risk of bias of included studies. So we developed a tool specific for the included studies. We conducted meta-analysis for primary outcomes. The strength of evidence was assessed according to the method by the Agency for Healthcare Research and Quality. The tool for the reporting quality had 6 items. Item 1 was there a well-described and unambiguous aim? Item 2 was, were the methods well described? Item 3 was, were all relevant results reported? Item 4 was there a list of included studies in text or appendix or additional file? Item 5 was, if studies were excluded, are the exclusions acceptably explained? Item 6 was, were all phases of the methods transparently described? The tool for the risk of bias assessment has 9 items. Item 1 was, Is there a clear and focused aim? Aim 2 was, is there a good match between aim and chosen methods? Item 3 was the chosen source the best alternative among others? Item 4 was data collection transparent and unambiguously identified? Item 5 was, does the classification of variables answers appear unaffected by prior knowledge about the results? Item 6 was an appropriate analysis method chosen? Item 7 were relevant considerations of missing data provided? Item 8 was any possible systematic error or biases taken into consideration in the data collection and or analysis? Item 9 is the conclusion supported by the data? We defined 3 primary outcomes corresponding to 3 indexes. The first one is the systematic review citation index, calculated as the number of RCTs that cited prior systematic reviews divided by the number of RCTs that were eligible to cite prior systematic reviews. The second one is the prior research citation index, calculated as the number of cited prior RCTs divided by the number of prior RCTs that were eligible to cite. The third one is the sample size citation index, calculated as the number of participants in cited RCTs divided by the number of participants that were eligible to cite. Here are 3 examples of how to calculate the 3 indexes. The first example was for the SRCI. A systematic review was published in 2000. Among 10 RCTs published since 2001, 2 cited this systematic review. So the SRCI was calculated as 2 divided by 10 equals 20%. The second example was for the PRCI. 10 similar RCTs were published before 2000. A following RCT published in 2001 cited 3 of them. The PRCI was calculated as 3 divided by 10 equals 30%. The third example was for the SSCI. 10 RCTs were published before 2000. These RCTs recruited 100 participants in total. A following RCT published in 2001 cited 2 of them, including 50 participants. The SSCI was calculated as 50 divided by 100 equals 50%. The literature search retrieved 6 studies from bibliographic databases. 3 were included for the SRCI, and the other 3 were included for the PRCI and SSCI. This table shows the characteristics of the 6 studies. The Robinson study had the largest sample size and was the only study that was not limited to a specific condition. The Hybrid study and the Robinson study were not limited to a specific intervention. The Robinson study and the 7 study do not have restrictions on the comparator, while the other 4 only assessed RCTs using placebo or no treatment as the comparator. The reporting quality of included studies was good, except that 4 did not provide a list of included RCTs, either in text or in the supplement. The risk of bias of included studies was low. The meta-analysis for the SRCI shows that, on average, only 68% of RCTs have cited prior systematic reviews. The meta-analysis for the PRCI shows that when prior systematic reviews are not available, only 21% of prior RCTs have been cited by subsequent RCTs. The meta-analysis for the SSCI shows that when prior systematic reviews are not available, only 24% of participants recruited in prior RCTs have been cited by subsequent RCTs. The strength of evidence for the SICI was moderate because the included studies were limited to a specific condition or intervention. The strength of evidence for the PRCI and the SSCI was high. This review shows that researchers frequently failed to cite prior RCTs. They may fail to appreciate prior evidence when designing new RCTs. In this review, we only found 3 studies for the SRCI. All were limited to a specific condition or intervention. More evidence is needed. For the PICI and SSCI, the included studies assessed RCTs published until 2011. More evidence on recent RCTs is needed. This concludes my presentation. Thank you.